The patient we are discussing, it's a 37-year-old. She was now para 3, day 0 post-vaginal delivery, post-successful induction of labor, the indication of which was post-AIDS. And she delivered a baby with a birth weight of 3.7 kg, subsequently complicated with retained placenta, which led into primary PPH, and the patient who suffered a hemorrhagic shock. From the peripheral hospital, they immediately initiated resuscitation. They had 2 IV lines. They started crystalloids and emergency blood products. They actually gave total of 4 units on their side, together with FDPs, and with the advice from tertiary seniors, they also started patients on calcium gluconate because of the massive transfusion they were doing to counteract the citrate effect. They also gave bicarbonate, and unfortunately, that side they didn't have a blood gas, so we didn't know the metabolic status of the patient. We didn't have a lactate or even the pH at the time, so they were just working based on the clinical picture. But when the patient arrived here, they had managed to do an evac in theater on their side. They started the patient on adrenaline. They even managed to extubate the patient before transfer. So when patient arrived, she was extubated. GCS was 15. She was still in shock, but the map she was now actually improving, because on their side, they were reporting low BPs with low mean arterial pressures. But when she arrived, the blood pressure at acid was 6, the diastolic was 56 with a systolic of 90 and a map of 78. The pulse was still tachycardic at 136 with a shock index of 1.4. She was comfortable on room air, saturating at 100%, and respiratory rate was 18. Something that we observed, they were giving adrenaline on the peripheral line that they were using. So patient on arrival as well already developed ischemic limb. The limb was swollen on the side of the IV lines. But otherwise, the patient was no longer PPHing. The uterus was well contracted with minimal, moderate lochia that was coming out. We continued the resuscitation on our side. We ordered more units. We did a blood gas for her. On the blood gas, the HB was actually 10, but the lactate was at 5.6 with a HB of 11.1. The pH here was 7.5 with a bicarb of 23.3. So the patient was still behind, but so that's why we decided to continue with the resuscitation. We ordered more red blood cells and we admitted the patient in a high care setting.
You can see the patient when she arrived here, she appeared much more stable, compared to how she was that side where she had systole of 60 with a diastole of 35 at some point. That's when we had to start adrenaline on her. They usually started when they called me for those adjustments, and they are further assisted with the patient. Indeed, the bleeding had stopped by then.
They managed to do the evac successfully, and the uterus contracted in response of the uterotonics. They had given her oxytocin and misoprostol PI.
Excellent. So that side, it would be nice to hear from Dr. Madibo. The patient was in respiratory distress. Respiratory rate ranging 38 breaths per minute to 40 breaths per minute.
We jumped to lasix as a first line, but this case, we had a patient with a low blood pressure. So this is a patient that needed more of ventilatory support and resuscitation than only to give the lasix once you are having at least the mean arterial pressure above 65 and patient is improving.
Dr. Moela, maybe before we talk about the management, because most of the times we manage without knowing what we're dealing with. So what could be the differential diagnosis? The patient with hemorrhagic shock, now with respiratory distress, post-intervention, anesthesia and surgery and evac. So first, why is she having a respiratory distress?
Oh, it happened after evac. Because initially I thought post-vaginal delivery, we might be having amniotic fluid embolism. And also we might have a pulmonary edema because this patient was resuscitated, had a massive transfusion, and anesthetic drugs as well.
Embolism is
very rare.
If I have to take you through it, you have to tell me what are the clinical features.
She didn't have the criteria.
For it to be number one.
The number one is the pulmonary edema in this case, because it's a patient that they were resuscitating with, they gave 4 units of blood in a period of an hour. That's what I thought it could be the first differential at the top of the list.
Yeah, perhaps pulmonary edema.
Yeah,
it's one top cause top five. We'll say top five. Number two, the patient who's in hemorrhagic shock. That's more, keep that in mind as you're answering that question. As you're telling your audience, what must the students think? Hemorrhagic shock, now they develop respiratory distress or increased respiratory rates or efforts. Increased respiratory.
So this patient is losing a lot of blood, which is red blood cells containing. So now the oxygen is going to be depleted. So I think that will be coming from that background pathophysiology.
What happens?
So now the patient is trying to increase, they are ventilating, hyperventilating because they are trying to increase their oxygen level from the reduced red blood cells. Because there's a reduced oxygen binding capacity for them. So they...
the binding capacity, carrying capacity remains the same. Just the volume now is the blood volume is low. Since the blood volume now is low. What happens when the blood volume is low to the patient? Peripherally?
They vasoconstrict.
They vasoconstrict. Very good start. So what happens then when you vasoconstrict peripherally?
So
what happens when you vasoconstrict anyone who bleeds, whether from car accident, from abruptio placenta, from placenta accreta or previa, when you bleed out, there is tissue hypoxia. As you said, the peripheral tissue perfusion becomes low. The metabolic processes that happens, they're no longer being perfused. It gets disrupted. And then what you have developed, the most important is called lactic acidosis. That's what the student needs to know. They develop lactic acidosis, which is a metabolic acidosis, isn't it? What does the body do in response to metabolic acidosis?
Try to hyperventilate.
You are going to hyperventilate. All right. That's basic principles of biochemistry, which you did. Fourth year, third year, isn't it? Anyone who develops metabolic acidosis, how does the body do? Whether it's DKA, whatever it is, isn't it? You are going to hyperventilate. But here you've got lactic acidosis from poor peripheral perfusion because of the patient just bled out. And then what happens the body tends to respond to compensate for that metabolic acidosis. And in this case, it becomes number one because you can see your lactate. When
it was high.
Lactate was fine. Normal lactate, tell the students what would be the normal lactate.
We want it to be at less than 2.
You want it to be less than 2. All right. We know once you go above 2, you're in shock. Septic shock, if you're in sepsis. Yes, hypovolemic shock patient as well. So already it tells you there is organ dysfunction. We're going to have an acute kidney injuries. You're going to have brain problems. You're going to have a lot of problems if you're not going to correct that. And then now if you've got this lactate, which unfortunately they don't have it in the peripheral hospitals. Dr. Muavha, I think we tried and spoke about getting blood vessels to the peripheral hospitals as well. So now when you resuscitate, it also helps you as you resuscitate. You've got what they call goal-directed therapy. So okay, now I see parents still behind it. It tells you to speak to behind the fluids.
Yes.
You need to then give fluids and look at the lactate hourly to see how is your lactate. This is a message I want for everyone to take home, for the students as well. When you guys are out there, for the interns, when they're treating patients, looking at the lactate and giving them fluids to see if the lactate is going down to your therapy. Fluid therapy is also very dangerous because it can develop pulmonary edema. All right.
Yes, they must also check the vitals. So as you are saying, the goal directed, targeted, for you to see if your patient is improving. On the blood pressure, specifically look at your MAP. At least it must be above 65.
Absolutely. Keep the MAP above 65.
65.
All right. And of course, pulmonary edema is one of our differentials. You need to examine patients.
Yeah.
We need to examine patients. How will you tell the patient with pulmonary edema, doctor? Dr. Dakalo? Clinically, what will you find? Very good.
They can be like fluid overloaded, like
the legs will be dematous. That will be pointing towards someone that you won't be giving fluids. All right. What will you find when you from the lung?
usually they have a crackle.
Absolutely, they're going to have crackles. All right. So in someone where crackles are not yet present, they are not dematous, legs are not dematous, the lactate is still up, you can still continue with resusc, like this case that we have. All right.
And we monitoring even the urine output as well.
And monitoring, very, very important, doctor. We are thanks for mentioning that. That's why I asked those guys, if you have a urine catheter, someone who's not producing urine, you need to be very cautious. Your fluid is going to be dangerous for the patient, isn't it? All right. We had slides to show how much food you're supposed to give there. Or maybe we'll have to show as we go.
Yeah.
All right. With a diastole of 40, still very low. Patient in distress. All right, this is a patient you're going to lose if you don't act, if you don't continue, you don't escalate your resuscitation. At this point, you can see you're giving fluids, she still remains low. You then have to add what they call an anatrope. All right, in this case, we chose adrenaline because of its availability in the peripheries. They've mixed 200 mils when they told me. We said, okay, since we don't have a central venous line, it's all right, you can put it peripherally. But peripherally, in terms of choice, Dr. Moela, where are they supposed to put it?
We
Where are
prefer
they
the
supposed to put it?
central line.
Yeah, central line,
Central line.
CVP is preferred. But if you don't have a central line, you're in the periphery, where are you supposed to put it? Peripheral. You can start. When you look at the guidelines, they say we can put it peripheral. But where is it supposed to be? You can tell the students it should not be on the hand. All right. Where should it be?
At
The
the
cubitus.
cubital.
Only here. That's what we allow it. Eh?
And
If you put
should
it
be-
here, what will happen? There's a risk of infection. It might lose the hand. All right, might become dark. But in this case, I think it's just a swelling.
Just
It's not
the
an
swelling,
necrosis.
yeah.
The difference between the two. However, the recommendation,
The
even for
cubital.
our guys then periphery, we need to assist each other when we're managing these cases. Yeah, because the emergency,
Yeah.
yeah, this is a time to reflect and say, where did we miss it? I think we also missed it when they called us, when they said it's peripheral. I assumed it was on the computers. You know, where was it when you confirmed? When she arrived?
So she had two lines,
She had
one
two lines, one
the
on
arm
the,
and the other one here.
on the decapitous,
Like-
one on the hand.
Yeah.
Yeah, but for the hand, Dr. Muavha, I think our message is that it's a no.
Yeah.
For adrenaline, they will not should not put on the hand. Ideally CVP, however, for certain purposes, during the transit peripherally, in the peripheral hospitals, they are allowed to put it on the
Cubitus. And then
She asked about adrenaline. How do we mix it? And what is our guideline? So how would she have done it?
Yeah.
In that case, doctor?
So commonly, what we use in our institute, there's a double strength and a single strength. All right, the double strength, that's why we put 20 milligrams in 200 mils of normal saline or renal lactate. The single strength, 10
How many
milligrams.
ampoules then?
So each ampoule is 1
1,
milligram.
10, 20.
All right. So each milligram is 1.
There's 20 ampoules.
Yeah, 20 ampoules in 200.
200 mils.
That one's when you're going to use a CVP. But that one, if it's extravasate, is
Yeah.
going to cause necrosis.
So in the peripheral.
In the peripheral
how
hospital,
many?
10 ampoules,
10
200.
ampoules.
Yeah,
And running at how much? Because you remember she was running at 150
absolutely.
mils per hour, you know. The good news of people like yourself joining Limpopo response team though is to clarify. You see, there is a lot of where doctors they don't know and they're not sure.
Absolutely.
Most of the doctors they withdraw, they don't do anything.
Mm.
But with these doctors, they did something that was quite high, right? So how much must they run, doctor?
So now it's 10 milligrams in 200 mils. How much are you supposed to run it? The dose is 0.05 mics per kg to 0.05 to 0.5. All right, this is the safety net.
The lowest you can
Yes,
use on a
0.05 mics per kg per minute to 0.5 mics per kg per minute. We can go up to 1 in ICU. All right, 1 mic per kg per minute.
So with that mixture, practically,
So-
Muavha,
Yeah.
Helena France, how much?
Absolutely. We got the same challenge because there, you see, this for you to able to run this mics,
Yeah,
You
you
need
need
the
an iPad
machine.
pump, an infusion pump for you to add this detail
yeah,
that we are saying.
yeah.
And someone's weight there to add 0.05, but nothing will give you a concentration. Just add put 10 milligrams in 200 mils. You tell the machine that, and then put the patient's weight, and then you say I'm aiming for 0.05. Then it will run itself, depending on the weight of the patient. That's the luxury of ICU
Yeah.
and being these high centers. But in the periphery, they don't have that luxury. And then we came up with an average and say, what can they be starting on? Looking at what we've been using. We say a minimum of 5 mils per hour. For the guy who's using a dial flow, he has nothing to run it on. It must be controlled, but you can't open it like a dress.
So 150 was compared
It's
to
what?
what you're saying, 5
Five.
mils.
It
So
must
150
5 to 20 mils.
was too much.
5 to 20 mils per hour.
Yeah,
So 150 mils is impossible. You can never run it.
yeah.
not in ICU, not anywhere.
Yeah.
By average 5 to 20 minutes. That's why our safety running of this drip. And then what will you be looking at as you run this drip, as you titrate it? You're looking at your blood pressures, right? How are they? Are they going too high? Are they remaining low? If they are remaining low, you need to move from 5 to 10. All right. If they remain low, you go to 5 to 15. All right. And then you can take it up to 20. And then this will be in consultation with us. We'll be guiding you throughout. These are cases that we, a pregnant woman, when they crash, we make ourselves available until the patient arrives. So we'll be helping you throughout. We'll be calling you like the case we had throughout the night.
I must testify, Dr. Muhlari, I was the one on call, but I called you, you were not on call. You woke up, it was in the middle of the night. It was around 1 o'clock or so, and he was available to assist. So thank you so much for that. Really appreciate it.
And this is a message I want to send to the guys in the periphery that because that kind of case like this, we find this once in a month, once in a while. So it doesn't get us tired. We're available for it. When it comes up, we get excited. We want to save this woman. We want to save this pregnant woman. Make sure they come to our ICU stable and well. You can see she came in stable compared to the picture that we had that side. The adrenaline didn't stop this side, because of the resuscitation that they did. So that's a dose of adrenaline that we will advise 5 to 10 mils, 5 to 20 mils, but this must be on a controlled manner. You have a dialysis flow at minimum, but infusion pumps are preferred. All right. And when the patient leaves, this is a message that I like that doctor that she put it up. When the patient was supposed to be transferred now from there to us, one will not be able to transport the patient on anatropes without the monitoring of vitals and without you monitoring that anotrope is running. Because if it crashes on the way, and so how can I put it? How long will you take a patient to crash with hypovolemic shock with a lat rate of 10? You can take it 35 to 40 minutes if you have stopped there. If you have stopped there, the adrenaline in 30 to 45 minutes, that woman will have died. So you need to think about it if you're going to transport someone like that with you stopping the anotrope. You just the BP going like this. If you stop an anotrope in an ICU, you just see the blood pressure going down slowly. Next thing is the cardiac arrest for the patient. So I think it was going to be very risky.
As much as we want the patient to come closer to Petersburg, but we have to do it safely.
Absolutely.
I think the patient will be better with the doctors in the hospital while we're waiting for the correct transport.
Yeah, I feel that.
So I think that is the message we need to do. Yes, the doctor is panicking on the other side. She may still have another Caesar to do, but she has a sick patient. So it's better for her to not do that Caesar and stay with that sick patient. What the doctors are unable to join, but I want to say something very exciting when you have young doctors like her who has a sick patient in front of them. They keep on updating us. Every 30 minutes, every hour, she was calling Dr. Muavha. Patient is like this, Dr. Muhlari, the patient is in this way. So I think the doctor has done so well. So we really wanted to give her flowers, but she can't join at the moment because of network, unfortunately. So let's open the floor to the team online. Dr. Muhlari, you've got around 38 people who are listening to us. We are excited that we are doing this. We have Dr. Amoko on the line. We've got Dr. Denga as well as always on the line. We've got Dr. Ndlovu Wongani on the line. We've got Dr. Ntope Wilfred. Doctors is there, and Dr. Upa, of course, no doubt, and Dr. Netozi. Is there any comment from the team online? You can go ahead.
Excellent. That's what are still coming. As Dr. Muavha is saying, when you've got a sick patient, this patient should not leave. You should not go away from this patient unless another doctor comes and deal with this patient. You need to be monitoring the patient continuously until the patient leaves your hospital. It's the same thing when she gets here. The doctor must not leave the patient until the patient is stabilized. So this is another message. And as Dr. Muavha said, this doctor did very well. When I called her now and then 30 minutes, every 30 minutes, this is a critical ill patient. She can die anytime. This is someone's child, this is someone's mother, and you are the responsibility doctors. And remember, we've been entrusted to take care of life, these patients. So our responsibility to exactly do that. Once these patients do not leave their site, to be checking what's happening, how is the urine output, be checking there, how is the blood pressures, how is the systolic. You get something worried, Dr. Muhlari, even before 30 minutes ends, Muhlari, let me call Muhlari again. Dr. Muhlari, I'm seeing this observation. I'm seeing that, that kind of management, we find it to be very good, and the outcome is just so good.
So, Dr. Muhlari, what fluids do we then give for such patients? Would it be normal saline, venous lactate, Boluven? Which fluid would be the best? Would it be blood? And how would you give and how much? Majaji Puji is in. Dr. Majaji Puji, do you want to make a comment on how you, on this particular patient?
Morning, colleagues.
Good morning.
Good morning. No, my apologies. I was struggling with the networks. So I would say for me, it was more of a learning curve together with the team that I was on call with on Monday. We really learned a lot, although we still need to learn more about the fluid management and how to prepare the adrenaline infusion. And so wish we can get an in-service training if I were to go and ask more about it.
Most important thing is that you stay in the lab, right? By being dedicated,
Yes.
and making sure that you update, you keep on, because the thing is, once the patient is accepted in Petersburg Hospital, it doesn't mean that the patient now is safe. Because there's a feeling that, oh, I've spoken to Dr. Muhlari, then patient is safe and you continue doing something else. So you have to stay there. And I like the fact that when the EMS came and it was not the correct EMS, you called and said, Doc, this is the EMS who came, but it's not the correct EMS. What should we do? So you were more concerned that the patient needs to arrive this side safe, even if she's critically ill. But she must not just leave because you want her to be gone in front of your eyes. You wanted it to be safe. So well done for that, doctor.
Okay, thanks a lot.
Excellent. All right. So
Yes, the choice of fluids on the slides, the choice of fluids, Dr. Muavha, that's what we'll be reading. It depends on the type of fluid that the patient has lost. Indeed, if someone has lost blood, they will require blood. However, blood is not readily available. We've got renous lactate, all right? We've got normal saline, we've got balsol, we've got plasmolite. Those are our main common resuscitative fluid that we have. 5% dextrose is not resuscitative. Maintenance is not resuscitative fluid. Half saline is not for resuscitation. All right, so your resuscitative fluid will be those first ones: renous lactate, plasmolite, balsol, and normal saline. However, normal saline is shined upon mainly because it's more hypertonic. It also has high levels of chloride. So there are concerns about hyperthermic metabolic acidosis due to that chloride that's there, which actually affect the kidneys. When it's given in volumes, about 5 liters, that's when you experience the hyperchloremic metabolic acidosis. However, if you are in the periphery, you don't have renous lactate, you don't have plasmolite, you don't have balsol, you only have normal saline, you'll have to start normal saline. And as I've said, that hyperchloremic metabolic acidosis won't happen with 1 liter. It will happen if you have given too much of it. All right, 5 liters of normal saline. That's when such concerns happen of AKI as well, acute kidney injuries associated with normal saline. So you cannot say, I'm not going to give fluids because I'm going to have normal saline, all right? You will have to give normal saline at that point. However, renous lactate is preferred. In our ICU, renous lactate is not preferred. ICUs where we've moved to plasmolite, balsol, those ones that got high bicarbs. So, it depends which level you are, isn't it? So that's what you need to be thinking as your resuscitative fluids. We've moved away from giving histostarch, your voluvens, mainly because of the acute kidney injuries as well that has been associated with high volumes of acute kidney injuries. In septic shock is completely contraindicated. In hypovolemia, anesthetists, they still give a bit, 500 mils. However, it's no longer as recommended. The recommendation currently is that please use your resuscitative fluids, which I've just mentioned, your renous lactate, your balsol. The question is, how much are you supposed to be running them? We have seen, studies have been showing that in our developing countries, our resuscitation fluid is very poor in terms of the amount we're giving. A doctor just connects and goes away, things are running. We're not monitoring. We're not having to go directed monitor. We're not coming back in 30 minutes, 20 minutes to look at the blood pressures, to look at the lactate, to see where am I going with this fluid. As we said, fluid can cause harm. If you give too much of it, you'll kill the patient. The dose is supposed to be 30 mils per kg per hour for the first 3 hours. This is what has been recommended. However, even boluses are still allowed as well. Fluid boluses, that's what ICU is moving at. The problem, Dr. Muavha, with this fixed dose of 30 ml per kg is the pulmonary edema that we're seeing. That someone just connect that and put it there and leave the patient alone for 3 hours. No, come back and look at the patient. Is the patient still requiring more of what I've given? All right. So boluses is somehow another way of giving it. Boluses, so those who are registrars will save 4 to 5 mils per kg over 1 hour. All right, that's a bolus. On average, we say 500 mils. All right, 500 mils to a patient, and the bolus, run it over 30 to an hour. And then after the bolus, reassess the patient. Examination of the patient. Look at the vitals. Listen to the lungs, on the patient, and see if you are still on the safe side. And then you can then continue giving your fluids as you require. Okay, and of course, monitoring your urine output. Am I getting there? Monitor your lactate every hour after giving a fluid bolus. Check the lactate. Is it going down? Check the urine output. Is the urine coming out down there? Because if it's not coming out, you are likely to overload the patient. But still, you could also be behind with the fluid if the lactate is still going up. So you need to be watching all those factors as you go. Your lactate is going down with that fluid bolus. Like, wow, this is good. My BPs are also going up. Let me give another one. Safety. And then you look at those, your urine. You practice safety as well. You're looking at a man overloading. She's not developing respiratory distress, as you said earlier on. Going to pulmonary edema, those are the first things you're going to see, isn't it? All right. Excellent.
No.
And is to say that, of course, we've mentioned it already, to say start vasopressors, no adrenaline, that's what we'll use this side. But I will say for the peripheral hospitals, adrenaline still remains the first choice due to the cost of no adrenaline. So adrenaline, that's what you're going to start at the doses that we've mentioned of 0.05 max per kg per minute to 0.5 max per kg per minute. Titrating to effect. You'll be looking, what titrating to effect are we talking about? We're looking at your map. Aim for a map of 65 and above. Yes, 60, you are still safe. 65, you are more safer. All right, it goes to 80. Now your map goes to 80. You must slow down your adrenaline. Back now. You want to take it out. Also, it's a medication. It's got side effects. It also raises the lactate. So you don't want to give it unnecessarily as well. All right. So target a urine output of 0.5 mils per kg per hour. Watch the heart rate. When a patient is improving, you are going to say tachycardia improving. I've seen patients coming here from different units, fluid behind, tachycardia of 150. Just like our case. How much was when she arrived here? 136. A doctor cannot go to sleep. You can't leave to doctor's room or to a doctor's house when you've got a pulse of 100. It's very high. You're almost going to what they call supraventricular tachycardia, which is 150. So here I'm in trouble. I can't go to sleep with this patient with a pulse of 137. That woman is going to die if you don't do anything. All right, you can't watch her. You need to call for help, like she did. What did we do to this one? With that pulse of 137.
With this one, we continued the resuscitation. We ordered more blood products for her.
Absolutely, you ordered more blood products with an HB of?
We had a HB of
10 on the gas. HB is 10. So another lesson that we're picking up, Dr. Muavha, is that do not rely on the HB. You see HB of 10, you think I'm not going to give blood. The patient has bled. The history is telling you I have bled out. My pulse 137. You're not going to watch that patient and think it's pulmonary embolism. Move to a new differential diagnosis. You can't do that. She has bled out. That's why that pulse is 137. It's nothing else. It's bleeding. The HB that you are seeing there, it's still more concentrated. It's a measure of concentration. It's not a measure of the total amount of HB in the body. It's a concentration measurement. And for that to happen, it takes time. It's an acute bleed, so you are going to rely on your other markers. The HB won't be a good marker at this point. Your lactate will be a good marker for fluid status. The most important thing is vitals, actually. Before I even go to lactate, Dr. Muavha, the vitals are telling you your examination of the patient. The patient will be white. You look at the patient, she is pale. You can come up with another differential diagnosis of almost pale with an HB of 10, and the she was bleeding. She has bled out. Your HB must not stop you from giving. We have seen that happen a lot. Patients crashing because someone said, no, HB is 13. Doctor, the patient is a abrasion placenta. She has blood. The BPs are 40, 60, but HB is 13. What is that? What is it telling you? The patient is telling you, I need blood. Don't stop giving blood because of that blood gas or HB that you have just done. You know, it's a concentration measurement. You know, it doesn't tell you much. So it's a bad mark at that point. It should not, it's unreliable. All right. So that's one message that we wanted to come out to then put up, you know. And I'm glad they ordered blood, they continue resuscitating the patient.
They gave FTP. They had FTPs in their hospital.
Yeah, yeah.
In that Odendal hospital, we need to be able to know who is the clinical manager.
Yeah.
Because they really save lives. We always have meetings, Dr. Muhlari, and say, these guys, in the hospital, they didn't do this, they didn't do this. And we talk so loud about it. But even when the doctors do well, we have to still talk loud about it. You know?
Absolutely.
So I'm really happy with what they have achieved.
Absolutely. Dr. Malibane, you want to come in? Thank you, Doc.
No, my point is just to reinforce what Dr. Muhlari is saying about the HP. So for those patients that you're doing cesarean sections, in the maternity book, we please ask you to indicate the estimated blood loss, because if you don't say it or you underestimate, it becomes difficult when the patient comes this side, where you start struggling in terms of how much the blood loss was there. And that in that way, it also affects the resuscitation.
Absolutely, absolutely. All right, good. So, hey, we left with 5 minutes. I just want to give the opportunity to the students. They've been listening the whole time. Yeah. Let's give them the opportunity. Let's start with you, Doctor. Just tell us, what have you learned quickly? We've got 5 minutes, and then we can give Dr. Muhlari and Dr. Moela to wrap it up. What have you learned from what Dr. Muhlari and the team was talking about?
One thing I can remember, one thing that just stood out for me was how the effects that adrenaline had on the patient.
Yes, excellent. You know, she remembers that when she's giving adrenaline, she's not going to be putting it on the hands. You were listening very well. Is it because you are listening or it was possible? From high concentration to low concentration, just 80. Guys, you must learn something from her. You must sit next to Dr. Muhlari. Information will just come like that. Dr. Moela?
I actually also just want to applaud the doctor for actually calling and asking for help quite early and being active in the resuscitation of the patient. Actually, it was first time I received a patient like this. I was happy because what she was explaining on the side, I thought I'll have. But when she arrived here, I was really, really impressed with it.
Wow. That's really having goosebumps. Because we don't find a lot of this. I think let's give the
Oh, thank you, Dr. Muavha. I think mine is also to applaud the team, Yako FH Odenda. They were also not sure. I think what we must take from it also as district hospitals is that listening to your left side in terms of ensuring that timeous consultation is important, because more often than not, you'd find that the consultants or the registrars that are on the other side are not given an opportunity to assist us on time because we get stuck with patients and only call later. So the fact that they jumped and requested help and they managed the patient, they co-managed the patient throughout, made a huge difference, other than if they were just running around, only call a consultant after 2 hours, more like the patient are crashed. So well done. I think it's a win for the team, and we really applaud it. So I think Lerna as clinical managers, we must just continue to support those kind of doctors like what Dr. Majadi will do, because they will do this behind the scenes when we are not even watching. So thank you so much. I'm happy, and well done to the team.
Excellent. Oh, thank you, Dr. Cooper. Because she's so good. I will learn her name so well. When she's coming for a registrar post, I already know her name. All right? Okay, Doc, just before we give Dr. Muhlari to give a closing remarks, can you say something for yourself as well?
I would like to say thanks to the team that I was working with on Monday night. Honestly, they helped a lot, the doctors and the nurses, and also thanks to Polokwane. Yeah, I really learned a lot on that day. Thank you for being so helpful. Thanks to Dr. Muhlari, Dr. Muavha, Dr. Moela. Thanks a lot. Thank you.
We're ending it at the high note.
Yeah, no, definitely. No, thank you, thank you, thank you, Dr. Majadebodi. Thank you so much. I think for us it's a pleasure from ICU to be involved very early. I just thank Dr. Muavha for involving us very early. From our side, if you had a bed, we prepared a bed for the patient. All was ready from our ICU side. The team was informed. So to appreciate the obstetric team to say, involving us very early, this made a huge difference for this patient. We're so pleased of the outcome. We are so happy and well done team.
It won't be nice for me not to say something about Dr. Muhlari. I called him in the middle of the night. I was on call, he was not on call. He picked the call, not only to give me an advice, we had to even speak to the doctor in the peripheral hospital. And then he said, Dr. Muavha, tell that doctor to update me as well, right? So it's a person who was sleeping who says, I'm awake now, and until this particular patient is safe and in the hospital, I'm not gonna sleep. Just let them update me. I mean, that is amazing, really. Dr. Muhlari, in a Limpopo obstetric response team way, let's say goodbye.
Goodbye.
Bye, colleagues.
Bye-bye.